Hello everyone, this is Dr. Sultan Moinuddin Shaukat Ali, and today we are going to discuss the third session in abdominal ultrasound, which is again a renal ultrasound. And before we start, I welcome you back to Iqramed Academy. Presently we are at a status where we know where kidneys are located, and we know how the normal kidneys look like. Now, in this lecture, we would see the various embryological variants or normal variants of kidney as well as abnormal variants, how kidney can be. Like sometimes the kidneys might be a horseshoe kidney, or you might have abnormal location of kidney like in cases of ectopic kidney. Sometimes the kidney might be absent, which is called renal agenesis. Sometimes the kidney on one side may be absent, suppose like on one side the kidney is absent and it is fused with the one on the right left side, whatever. So that is called cross fused ectopia. So all this embryological variants we will be seeing in this session. So without any delay, let us begin. Okay, so as always in my sessions, I always discuss the basic anatomy, basic embryology before I begin. So I would start discussing the basic embryology before I start with the various images. So where does the human kidney develop from? The human kidney develop from a special structures. So in embryonic life there are pronephros, mesonephros and metanephros. Human kidney originates from metanephrons. So human kidney is metanephric in origin. This is the nephrogenic duct from which out of this all of this degenerate, and from metanephros the human kidney develops. Now human kidney is metanephric in origin. So initially it is at a high level. And later on it descends downwards into the lumbar region. That happens with testis. That testis initially it has high level, that is intra-abdominal, and it descends downwards via the inguinal canal into the scrotum. This happens with testis. So descent occurs in case of testis. But the reverse, that is kidneys develop in lower pelvic region and then they move above. So this is called ascent. So ascent occurs in case of kidneys. So descent of testis and ascent of kidneys occurs in embryonic life. But what if the ascent doesn't occur? Then the kidneys will continue to remain in the pelvis, that is pelvic kidney, ectopic kidney. Now sometimes there might be an abnormal SMA or abnormal vessel which might inhibit the upward movement of the kidneys, and that leads to formation of horseshoe kidney, where you have kidneys which looks like a horseshoe and there is isthmus in between them, that is called horseshoe kidney. Now one of the very important embryological part which you should know is that when kidneys develop, it develops as multiple islands, which later on this island fuse together to form a single kidney. As kidney develops from multiple islands which fuses and forms a single kidney, so you will see what is the application of this. The clinical application is that because of this embryology, you will find that the fetal kidneys have lobulations. So fetal lobulations, what you see, are a result of this embryological basis. So in fetal kidney you find that there are lobulations. That is because of this. Now very important clinical thing, how do you differentiate whether it's fetal lobulation in the kidney? So kidney looks like this. The outer surface of the kidney might look like this, which is one of the normal embryological variant, and it represents fetal lobulations. Now, how do you differentiate if it is fetal lobulation versus scar? How do you differentiate if it is not a fetal lobulation and it's a fetal scar? So you need to see if where are the medulla. So if suppose there is medulla here, there is medulla here. Now I tell you to remember my first lecture on kidney. Did you remember I told that there is the cortex which enters in between the medulla, that is called column of Bertini. This is called column of Bertini. So if the lobulation, that is the inner dip of lobulation, corresponds with the column of Bertini, it corresponds with the column of Bertini, then it is lobulation. If the dip goes along the column of Bertini, then that is lobulation. But if it is not corresponding, suppose it was anywhere, suppose it was here, which is not corresponding to column of Bertini, it was here, then that would favor scar. Scars can occur anywhere, but lobulations will always take place along the column of Bertini. So that is how we differentiate scar versus lobulation. So we saw one of the important embryological basis where you saw lobulated kidney. Then we saw horseshoe kidney. Similarly, there can be an entity which is called, suppose this is the kidney on the right side, and the left kidney might be absent, and the left kidney might be there on the right and might be fused with the right side. This is called cross-fused ectopia. Cross-fused ectopia. So the ectopic kidney and the ectopic kidney is there on the right side. Now the cross-fused ectopia may be of multiple types, where both the kidneys can be, this is called S-shaped type. Both the kidneys can be like this, where one kidney is here and the second kidney is attached like this. This is also possible. Or there can be a pan-shaped cross-fused ectopia, where both of this might be fused like this and the ureter might come out from in between them. So various possibilities of embryological defects or embryological variants are possible in cases of kidneys. Now one more important thing which I would like to tell you here is that if you have gone through our sessions on gynecology, various lectures on gynecology, we have discussed that whenever you have Mullerian duct abnormality like MRKH syndrome or uterine agenesis, unicornuate uterus, in all these cases you should look for renal anomalies, because renal anomalies and Mullerian duct anomalies goes hand in hand, because development of kidney and development of the uterus via the Mullerian duct takes place together. So the defect in one can be associated with defect in the other also. And then there are multiple syndromes where you can have multiple defects within the kidney. Now I would like to start with one special topic which is called dromedary hump. Now this is interesting because sometimes this is often confused as RCC or renal tumor. Normally you see that the kidney appears like this. This is the renal pelvis. Okay, the kidney appears like this. Suppose this is the cranial end, superior end, this is the inferior end. But in this case, there is a hump like this. And sometimes people might confuse this hump for the presence of some lesion. Now, how do we differentiate whether this is actually a lesion or not? So, very important, you should see the cortical thickness. So, if you see the cortical thickness would be uniform. What thickness you see in this area, the similar thickness you will get it in this area. Whereas in case of mass, you will find that if there is a mass, you will find that if this is cortical thickness, here is mass, the thickness over here in the region of mass will increase. So that helps to differentiate whether this is just a dromedary hump or it's a renal mass. In case of dromedary hump, there is uniform cortical thickness rim, whereas in case of renal mass, you will find that the cortical thickness increases. Okay. And second thing is, if you see the vessels, there will be no change in the vascularity pattern if you see it at upper pole, interpolar region and the lower pole. But in case of dromedary, in case of RCC or any renal mass, you will find that there will be sudden change, splaying of vessel, increased vascularity in case if it's a renal tumor or RCC. Now, dromedary humps are most commonly seen along the left kidney and it is believed to be caused by the splenic impression. And most important, why should we know it? So that we don't confuse it with tumors. So here this is a beautiful image which shows you this is how a dromedary hump is. This is the dromedary hump and this is a camel with its dromedary hump. And so look here, this is the left kidney and beautifully you can see that there is dromedary hump. And this should not be confused that there is some lesion here. In fact, you should see the cortical thickness. This is the cortical rim. If you see the cortical thickness here and the cortical thickness in this region, they are nearly equal. That means that this is physiological hump, this is dromedary hump and not a mass lesion. This is not a mass lesion. That is how you differentiate mass versus dromedary hump. Now coming to horseshoe kidney. These are one of the most common type of fusion anomaly which you see. Now when will you suspect that the patient has horseshoe kidney? Now normally kidneys are located like this in the body, like this. So the upper pole is slightly medial, the lower pole is slightly lateral. Similarly, on the left side, the upper pole is slightly medial and the lower pole is slightly lateral. But in horseshoe kidney, there is a connection at the lower end. So the axis of the kidney is rotated. So horseshoe kidney is reversed. So it looks like this. The upper pole goes lateral and the lower pole comes medial. So if you see on ultrasound, you won't be able to focus well the longitudinal length and you will feel that somewhere the kidney is not coming in the view and the upper end is lateral and the lower end is medial. In all those cases, you should put your probe in midline and look if there is isthmus or not. And if there is isthmus, then it means that this is a horseshoe kidney. So horseshoe kidney appears the one with isthmus. And there are various complications which can be associated with horseshoe kidney like hydronephrosis. Sometimes there may be stone formation or sometimes it can be just incidental findings. It might sometimes increase the chances of infection. It can be associated with aneuploidies like Down syndrome, Turner syndrome, Adverse syndrome, Patau syndrome, and sometimes it may be just an isolated anomaly. Ellis-Wren-Crevald, Fanconi's anemia, Prader-Willi, Vectral anomalies, all this may be associated with horseshoe kidney. Now, horseshoe kidney is said to be associated sometimes with Wilms tumor, carcinoid, TCC. Now, look here, this is the image of horseshoe kidney, one of the most common fusion anomaly. So, this is the kidney on the right side. So if you see, this is the kidney on the right side and this is the kidney on the right side and this is the kidney on the left side. In center you can see this is IVC, this is abdominal aorta, and here you can look that there is a connecting link between the two kidney. This is called isthmus. This is called isthmus. So isthmus is the connecting link between the two kidney, which is very nicely seen in the epigastric region. Okay, and once you see this, the diagnosis is confirmed that it is a horseshoe kidney. Now we move to a separate entity of system which is called duplicated collecting system. But before I start duplicated collecting system, I would take you to I would like to tell you an important thing so that you understand this thing well. Some important rules and embryological part associated with duplicated collecting system. So suppose in this case, suppose this is kidney. Okay. When we say duplicated collecting system, we are referring to ureter. So we might have a case where there are two ureters, one originating from upper pole and one will be originating from the lower pole. Now here I want you to tell a special law which is called Weygert-Mayer's law. Weygert-Mayer's law. So what is Weygert-Mayer's law? It states that the upper ureter, when it inserts in the bladder, it goes down. The upper ureter, when it inserts in the bladder, it goes down and there is urethrocoel at its end. So upper ureter inserts down and there is urethrocoel at its end. And the lower ureter has normal insertion. Lower ureter has normal insertion, but lower ureter shows signs of vesico-ureteric reflex. So in lower ureter which inserts above, you have vesico-ureteric reflux, and in upper ureter you have urethrocoel. So sometimes you find that there is hydronephrosis only as one part of the kidney and not in the other part. Suppose only in those parts where there is urethrocoel, you might be having there is hydronephrosis. So whenever you see focal hydronephrosis, focal calectasis and urethrocoel in the bladder, you should suspect that this case can be duplication of ureter. There can be two ureters or double ureteric system, duplication of the collecting system. Now this is a very, very important concept which you should know, Weygert-Mayer's law. Now with this concept in our brain, we will move ahead to dilated collecting system. So this is one of the most common congenital renal tract anomalies, and it is characterized by incomplete fusion of upper and lower pole moieties. So the ureter collecting system remains different as they develop from two different moieties. So it's one of the anatomical variant, but we have seen two important complications of, and we have seen the Weygert-Mayer's law where upper ureter which inserts low, it has got urethrocoel and that might lead to obstruction and focal hydronephrosis. The lower ureter inserts normally, that is above it, and it has high chances of complication which is vesico-ureteric reflux. So whenever the patient urinates, there is a reflux from the bladder into the ureter, and depending upon the grades there can be again the thinning and hydronephrosis of the kidney. So these are the two important complications associated with duplication. So on ultrasound, when there is no obstruction or no hydronephrosis, you might miss it. Sometimes you might just detect urethrocoel, and that urethrocoel should guide you that we should think that this can be a duplex system. Okay. So this is how a duplex kidney looks like. So there is one ureter and there is second. Of course, there can be focal hydronephrosis, and we have seen the Weygert-Mayer's law. This is how a urethrocoel appears. So I'll show you the appearance. So this is how urethrocoel looks like, You look at this image, you can see that this is the bladder, and in the bladder you see something which just looks like a Foley's bulb, but the patient will not have any history of insertion of Foley's. This is very classic appearance of ureterocele. So whenever you have ureterocele, you should always rule out whether there is a duplex kidney or not. Again, this is in launch. You are clearly able to see dilated ureter with ureterocele. This type of appearance is called adder head or cobra head appearance. Now, the next entity is ectopic kidney. Now you know that normally the kidney should be located in the lumbar region, in the renal fossa, retroperitoneally, but sometimes the kidney might be located at other places, and that often happens when there is MRKH or uterine anomaly or other Mullerian duct anomalies. So it might be also associated with MCDK, multicystic dysplastic kidney, presence of, and whenever there is ectopic kidney, that can have ureterocele, vesico-ureteric reflux, PUJ obstruction, all these things might be associated with ectopic kidney, because whenever the kidney is ectopic, the course of ureter also becomes ectopic, and then you might find that the thing is problematic. Now, an interesting thing, let us see. Suppose this is abdomen. This is abdomen. Now, suppose you see the ultrasound and the right kidney is present on the right side, and you see the left kidney is not there here, and there is one kidney here. Now, out of these two kidney, which one will you call right? This is urinary bladder. Out of these two kidney, one is above, which is kidney A, and one is below, which is kidney B. Out of these two kidney, which of this will you call as right side kidney? So the thing will depend on the ureteric insertion. So you have to look at the ureter. Suppose the ureter of this kidney goes like this and inserts here. If the ureter is inserting on the left side, that means this kidney A is a left renal moiety, and if the ureter of B is inserting on the right side, that means kidney B is the right renal moiety. So how do you understand whether it's a right renal moiety or left? Based on the insertion of the ureter. So based on where the ureter is inserting, you tell whether it's a right renal moiety or a left renal moiety. And whenever you see ectopic kidney, you should always look for other defects, especially GI defects, anomalies of the vertebral column like spinal dysraphism, genital tract anomaly, anorectal abnormalities, spinal cord abnormalities like diastematomyelia, and meningeal abnormalities. So we have seen ectopic kidney may be associated with vesico-ureteric reflux, UTI, or sometimes it might have ureterocele, renal calculus, and we also, one important entity which I had discussed earlier, that normally we do not see ureter, but ureter can only be seen if there is associated hydronephrosis or extrarenal pelvis. So normally you see, if this is kidney, the renal pelvis goes like this. This is what happens normally. But in certain situations, in some, it's an anatomical variant where the renal pelvis goes this way, and then the ureter is normal. So the entire course of the renal pelvis is extrarenal, and that is the reason why we call this as extrarenal pelvis. Now why is this thing important? Because if there is extrarenal pelvis, this can be confused as hydronephrosis. You might say that the patient has hydronephrosis, but actually the patient doesn't have. So how do you understand whether the patient really has hydronephrosis or not? So in order to really say whether the patient has hydronephrosis or not, you have to look if there is hydroureter or not. So if there is associated hydroureter also, then you might think yes, then the patient has hydronephrosis. The second important thing which you should look for, is there any obstruction there? Third important thing is whether the callicial system is dilated or not. If callicial system is also dilated, then there is hydronephrosis. And if the callicial system are not dilated, then you should think that this can be an extra renal pelvis. Very important. So now we have seen multiple variants of the kidney, including horseshoe kidney and extrarenal pelvis, and our next session would be based on pathologies. And just to enlighten your brain, what pathologies we would begin with, we would be beginning with renal cysts. So here you see that this is a normal kidney here, this is normal kidney, and if you see, this is normal kidney in trans, this is renal vein, and you can see very clearly there are no focal lesions within the liver, within the kidney. But here you see that this is kidney, and you are able to see there is a well defined anechoic cystic lesion within the kidney, which is exophytic, and it's disturbing the contour of the kidney. But there are no solid component, it is completely homogeneous, there are not even any septa looks like this, there are no echoes or no solid component. So that means this is a simple cyst. So in our next session we would be discussing on multiple cysts and some cystic diseases of kidney. Thank you.